Okay.
Got it.
So this is week one, group C, discussing shortages for clinical licensed social workers.
Introduce yourself.
Okay, I'm Faye Huang.
I am Khushbu Shah.
I am Jenny Kim.
And I'm Angel Doe. Okay, so for the assignment, there were a couple items we have to identify as part of the case study. So we have to identify the long and short-term causes of the shortages for licensed clinical social workers. And then also the additional data that we would need to look or evaluate in order to kind of like get down to the root cause of the shortage. And then what are some potential like recommendations or remedies we want to approach to address the issue, right? So,
Okay.
Right.
Do we want to just start with the root cause real quick? What we know is the issue?
but we don't know the root cause.
Oh, I'm thinking of the you're right,
Short term?
go ahead.
Short-term
Let's start with
causes.
short term.
Yeah. Yeah, we can start with the short-term causes.
Okay, short-term cause is for
Affordable Care Act.
right, the Affordable Care Act expansion that led to
Increase in patient volume,
Of Medicaid.
requiring more social workers.
mhm. Okay, what else?
The available options for the incentives, the wages and the bonuses,
Competitive
competitive.
wages and sign-on
On
bonuses.
bonuses by other organizations.
Yep. And then
Or
anything
long
else?
term. I think
Long-term reductions in the faculties for the nursing programs.
Yes, faculty reduction at local university,
Yeah.
Mhm.
which cause a delay in releasing new licensed social workers. There's also a delay,
In wage increases.
yeah, our organization's wage increase.
So the one thing I found about those delayed wage increase, and Khushbu, I don't know if you might have the information to give us some ideas,
Mhm,
but
mhm.
according to what I found off of ZipRecruiter,
Yeah,
they said that as of June of 2022, so just this month, they did a little survey, I guess, and they found that the average for a clinical licensed social
68.
worker is 70,000 a year.
I saw that too. That's like $33 an hour.
Yeah, it's extremely low for a master's
Yes.
level license requirement.
what
That's-
was it? Can you repeat?
That's the article I was reading.
70,000.
Yeah. So it's $33 per hour, and the minimum requirement most of the organizations now have is a master's. They used to
yeah.
have it bachelor's, but now
Masters and
they're moving towards
102
masters.
weeks of training.
Wow.
Yeah,
So that's like an additional 2 years of training.
yeah.
Um,
That is more of a reason that it's been challenging to hire. And it's different in different organizations of how much they're paid, like county versus a private hospital. But that's like the average salary.
Wow, national average, yeah.
Yeah.
Yeah, that's California rate.
Really?
California.
That's California rate. That's not even
California
national rate. If
rate.
it's national, it would be even lower.
Wow.
Yeah, so.
So, yeah, that's interesting. That wasn't discussed in the lecture, right? Like, basically, what like, that's, your salary would be a factor in drawing you to that industry, right? Or prevent you from going to that industry. So, let's see, how
It's
can
like
we?
a domino effect.
Yeah,
Yeah,
Mhm.
I sent you guys a link later on if you want to take a look at it, but that's the exact same information.
wow.
Yeah,
So, but the delay in wage increase, like this is just talking about strictly like our organization delay increase to match like the competitors, right? Not so much like the wage increase to match other profession.
no, Yeah.
Mhm.
Yeah,
So how do we want to word like basically what we were just talking about?
I think that could come more after in the remedies also to explain more, but what I understand from this is we may have to even get the approval, right? If we have the supporting data and we're presenting it, that process will still take a while for us to get the approval to increase that wage. Maybe that's the delay that's being caused.
Yeah.
Yep.
Yeah.
Yeah.
So long-term causes faculty reduction at local universities, delay in wage increases to match competitors. And then there was another one, the minimum.
the minimum
Staffing
staffing
requirements.
requirement.
Yes.
Definitely can't
Um,
beat that.
and Kushbu has a real scenario of 26 providers to one LCSW. How is that possible?
It's
It
not.
is not, and we had to, but it's complicated because it's a county hospital. The person who is who's not here currently is on maternity leave. And sometimes people tend to extend it from 6 months to a year. And then now you have that position that you can't even fill, but then that position is for that person who's on maternity leave. So it's kind of that time period where you are short, and that's what you have to do.
So from what I understand for government entities like ours, when someone's on maternity leave, you may be able to get a temp position, but in
Substitute.
some cases, the amount of
Yes.
training required doesn't make any sense. So they'd rather just go without. What is the repercussions of not having a clinical social worker available for patients?
It impacts the patient care that you're giving to your patients, because especially right now after the pandemic, there are a lot of people that are needing that kind of specialty, the counseling with the mental health crisis that they have. So they really need that particular social worker to be available for counseling. I mean, that role cannot be filled that easily. Psychologists are available with us in our clinic, but it's very specialized. So, and even if we were to have a temporary, let's say for a 6-month temporary position, even full coded are so difficult to hire. So temporary makes it even harder to have somebody agree to be there for 6 months, unless it's someone new grad and they really want to get that experience, and they'll agree to do that temporary position.
There's no
Okay.
really good incentives to be.
Yeah. So
And not
I
with county hospitals.
gotcha. So that brings us to the last one that Angel just wrote down for licensing. So they need a lot of training and master's degree, and we're short on
Faculty positions too. Yeah.
Graduate level education, licensing, and
graduate level and like 2 years of training after graduation.
2 years of training.
Post grad. Yeah.
Okay. Any other long-term causes? Oh, well, the other thing we mentioned, but we didn't write down was the like low incentive, right? Basically.
Yeah. Low incentive to,
Um,
oh, how do we word that?
how do you, for the profession?
No, yeah, no, low profession incentive for profession.
Incentives? As in, are we talking about like bonuses or we're talking about,
Financial,
yeah,
Yeah.
okay.
low financial incentive. Um,
Yeah.
To pursue the career.
Yeah, to recruit temporary short social workers. So many. Okay, I think that's good enough.
Yeah.
Okay, so additional data needed. I think the first one is to know what is our competitors' rates right now for
Mhm.
hiring and the
Yeah.
sign-on bonuses.
so we all agree on that, right? Is
Yeah,
Yes.
we need to know competitors, wages and sign-on bonuses and how they compare to ours, right?
Mhm.
and the other one was like the
Just,
graduation. The number of graduates that will be available for hire per year,
Mhm.
just so that we don't overhire temporary social workers. You had a
Yeah.
really good way of saying it, Angel, in your wording here. I see.
And the ratio of the social workers to the patients or the providers.
Oh,
Yeah, that's important. Ratio
Yeah.
of
LCSW to patients or providers based on the health center policy, because some health centers look at the number of providers versus some look at patients. How many patients can a particular social worker see?
Mhm.
ratio
Yeah.
of LCSW to
To
patient or
patients or providers based on the health center policy. Yeah.
Well, it was fate. It was the other one is the number of enrollments into programs. Working
Number of
with
enrollments, yeah.
universities.
number of enrollments in
Of
the
s- Mhm.
Nursing. Yeah.
Yeah, and maybe, yeah, the number of enrollments in the programs at the university and considering opportunities for collaborating between the organization and the educational sector to support and increase success rates for students, advertise the program and support the students through the program.
offer
Assistance.
Mhm.
Incentives for what's it
I-
called when we contract with the schools to have their students come do their interns and
like basically
program.
like an internship program or a mentorship program, right?
Mhm.
Internship. Yeah, that would be nice.
Mentorship program.
Residency program.
to increase
social work
yeah to
residency
increase the
program.
success rates from from the universities.
So we are still trying to find out if this is available in that university, right? This is more of the additional data needed, not a potential remedy.
Oh, you're
No,
right.
we're in the data. But it
So
goes
data would be success rate for the students, and those actual two is the remedy,
Yeah.
Yeah.
center remedy.
Number
Enrollment.
number of enrollments in the program of the university.
I
Yeah,
like
and
what you said,
and
Faye,
success
right?
rate.
The success, yeah, success rate.
Yeah, number of enrollments and success rates in the program.
Yeah.
And then potential remedies, we can separate like short-term remedies and then long-term remedies. Those two already there are like long-term remedies we want to continue.
Right.
Short term would be like hiring temporary staffs or hiring out-of-state staffs to make up for the shortages that was mentioned as one of the options in our readings.
While we appeal, right, to the
Mhm.
board of directors or
Mhm.
negotiate with the union.
Um, Jenny's hiring.
We
Uh,
may need to recruit staffs from other states or out of the area to meet the needs due to the current university's difficulty in producing all the students that we need.
But when you hire out of state, it's just like,
Temporary,
Temporarily.
yeah. But then,
it's not, is it though? Like technically, when you hire out of state, it's just hire, there's no like logistical difference in than hiring in state.
yeah, maybe.
I think most of the
Wow.
time when they do out of state, like from radiology side, like techs, we hire from out of state, and those are all going through a contracting system. So there's a national contracting system, just like nurses. Nurses and techs are under like different types, but it's a pool of candidates throughout the country. They call them travel techs,
Travel.
or yeah, so travel nurses.
So
Oh,
it's
okay.
not
Are they
so much-
yeah.
cheaper?
it's not so much hiring
They're
out of
not
state,
cheaper.
hiring from.
Oh,
a
they're
temp-
not.
They're more expensive.
Yeah,
Yeah.
but they're basically temp employees. They're not permanent. They
Okay,
can turn
hiring
permanent.
temp employees. That's one short-term memory remedy.
Hiring agency.
Yes, that sounds
Mhm.
better.
Contracting.
Another option is if other departments are also using the same, depending on the organization, some of them actually separate their clinical social workers so that they're not together, so that they're
Yeah.
different departments for cost centers and payment purposes for cost allocations. So if they can share their LC to SWs. So
Cross-train the staffs.
I mean,
Specialty.
to avoid, so I
Yeah.
said it's to avoid dead weight loss due to inefficient allocations. So
Mm-hmm.
if one department has more patients that requires this on one day than another, maybe we can push more social workers into this department for the day, and then we can allocate them back to wherever else they need to go on another day.
Yeah.
That way we have a full pool for everyone to use.
So are you saying, if I'm understanding you correctly, like certain departments will have their own license LCSW? And it's not that the LCSW have its own like cost center that they provide service for, but everyone hires their own? Is that-
So it's like,
In some cases, is to allocate costs, right? Remember
Yeah.
how we talk about cost sharing and versus, you know,
Okay.
yeah.
Not- yeah, in addition to make up for the shortages, I know like for our organization, there's like 4 social workers per unit, but when they're short, all these social workers just kind of do the whole floor. So just kind of cross-utilizing.
Yeah,
Mhm.
that
making
is
up for the
possible.
shortages.
Yeah,
Yep.
because we
So-
have multiple primary care clinics, and each primary clinics has like 20 providers. So in cases, let's say my primary care is short, you can reach out to the other ones to temporarily help out
Yeah.
while we are hiring the new LCSW. Yeah, that's a
Yeah.
So
possibility.
yeah, like
The cost-
allocation
Yeah.
of labor by need. So
Yeah.
distribution or allocation by need.
So
Yeah.
cost utilization of the employee within the organization, I thought that was just assumed, right? If you're short, then that's how you float people operationally, but like with the
Not
remedy.
all departments are that collaborative.
Yeah, because the units will fight
Yes,
for their social
yes.
workers.
Yeah.
Yes.
Usually. Where did she go?
Some of the units fight for their free time just because what if one patient shows up and needs them? Not like they're there now, but what if they show up in the next 5 minutes and she left?
Yeah, it's like contagion.
Yeah, it's not a sustainable option. It's, yeah.
So
That's bizarre.
it might be important to communicate.
Yeah, I thought it's more like clinical dietitians where they're their own department and then you get your list of patients that you have to see that day. But if your coworker doesn't show up, then your list grows by,
Yeah.
double.
think it's a mix of that,
It's a
and
mix
then,
depending on the organization that you're working with and yeah, and I think sometimes when when let's say one department has to bill out for that cost most of the time, they may take it on themselves as this person belongs to us. But yeah, it depends on the organization. So we'll assume this one requires it.
Yeah, so
I
cost.
was thinking, like, when I thought about cost utilization in my discussion, I meant like, if you were Kaiser at Santa Clara, you would borrow social workers from Kaiser in Palo Alto or something. Like, yeah.
Well, that's true too. And that could
Yes.
be the case. Like UCSF has multiple campuses. We could easily send our techs from one place to another. If we need more MR techs that day in one location, we push them over. So
Uh,
yeah,
location, right?
Yeah,
by location or campus. Yeah,
that's good.
yeah, that's good. Cross utilization.
Yeah.
Um,
What
What-
else? The short term. Giving it to the board of directors and union negotiation, is that short term?
I think
wonder if
short
that's
term
a-
remedy also includes like allowing more overtime.
yeah,
Oh, yeah. Mhm.
That's
And also giving more incentives for hours work. So like if you're working that many hours, there's a bonus at the end, and the bonuses usually correlate to the number of hours worked.
Mhm.
Yeah,
So-
approving overtime is a good one.
Yeah, we had that at Stanford, but I don't know if it made it to the children's hospital, Jenny.
What?
On the adult side, we were so short-staffed during the pandemic that there was incentive bonuses for
not
working.
us. Not us,
Uh,
because the children's side wasn't as impacted by the pandemic in comparison to, so what they did was they actually cut our hours.
Yeah, I think we got the cut side too.
Oh, yeah, we
Um,
went through the cut like the first year, and then the year
Yeah.
after, just there was no employees, so then.
Yeah, and then it started to
Oh
go.
yeah, now it went
It's
backwards.
that cycle.
This is
it's the
exactly what we're talking about, that
surplus and
cycle of
shortages.
Yeah, the supply and demand.
yeah, approval of overtime and then the additional incentives for
Mandatory
production.
overtime.
I know, basically it becomes mandatory overtime.
Mandatory.
It was
But yeah,
The,
incentives for additional incentives. Is there additional
Oh.
incentives
uh,
or
Extra hours, right? Additional
Yeah,
hours.
for working
Sometimes they
overtime.
offer weekend. Yeah, weekend. Can you work on a weekend?
yes, exactly. Incentive for working overtime. What else? Do we know if,
Oh,
like,
we can do like I don't know. This was like an article I read for my capstone, but what they did was like categorizing the patients based on high risk requiring social
Yeah.
work assistance, and then categorizing based on that for like priority patient.
Yeah.
yeah, I think that's a good one too.
Sorting the referrals based on the urgency or prioritizing.
Yeah.
Categorizing.
prioritizing, referral based
Based on
patient-
risk levels or
Yeah,
based on
care
patient,
risk. Or,
Risk
Yeah.
level.
patient risk level?
Yes.
yeah, patient risk level. Because this one's specifically talking about substance abuse, right?
yeah. Substance abuse.
Yep, substance abuse and.
Those are good for short-term remedies.
Long-term remedies,
Yeah.
let's go back to that. The long-term remedy was our like recommendation for the wage increase, right?
Yeah, union negotiation and board of directors. Mhm.
Collaboration
Collaboration
with
with
Universities.
local and out of area universities. I really don't think it just has to be local. I mean, we start with local, but maybe just expand ourselves a little bit to say that, hey, we need people like those that you're training right now. So we're open to interns, coming to check out our facility. Yeah.
Mhm. Offer internship or mentorship programs to increase success rate. There was something else on this one that I thought of. Oh, like providing going the opposite direction, like providing the university our staffing challenges and like staffing shortages data. Maybe then if I was the faculty, then I would say, well, we have like this local hospital has X amount of like positions that they need to fill, but they can't find candidates. So that would be like their justification for bringing on more faculty to expand the program.
Mm-hmm.
Yeah.
Yeah, so collaboration with the universities to understand the need for LCSFs.
Demand.
Staffing, information.
To support faculty increases.
Mhm.
Oh, for justification of
Demand for LCSW.
justification of hiring more faculty.
Faculty. Were there other long-term remedies?
How about retaining the current staff that you have or avoid burnout?
Can we
yeah.
consider, I know they said they're very specialized, but what are the other options if they're not available, Khushbu? Like in your clinic, you said psychologists, maybe we can use psychologists in place of them if we need to. So maybe one long-term remedy would be to consider having new psychologists or some psychologists fill in on the times that are available, because
I think that's a good point, but that would go under the short term. Because they can probably fill in while you hire new ones, but psychologists are much more expensive. I mean, they get a higher salary than the LCSW.
what's
So
the
they won't
level
be able
below
to
that?
change.
Is there an option for someone that's below that level that would do that?
No.
Okay, so short term, we have utilization of
Yeah.
psychologists. Nice. What about at the training stages? Can interns before graduation and during training be allowed to
I
work?
think you have to operate under the supervision of someone.
Supervision. Yeah, they would still need supervision.
No, I'm curious. I'm asking because there's, how we have residents and then we have
Yeah.
attending.
Yes.
Residents can still see a patient and discuss the matter with the attending without the attending being needed at that position at face-to-face contact. And that allows for more visits to be done and more patients to be evaluated. So if that is an option, like an education, a resident level LCSW.
I don't think they have those like different.
So with residents, like you said, Faye, it's a possibility, and there are R1, R2, R3, meaning if they're in R3 in their third year of resident program, then they can see patients individually. If they are in R1 in the first year, they still cannot see individually. But in cases of license, we may have to see if we have one already, and if we are hiring another one, then we can hire the other one as the first one as a supervising, and this one just
because there would be a
helping out with it.
supervising.
Yeah, that is a possibility to have the
Yeah.
current one as the supervisor.
Yep. Yep.
Yeah.
So I think that's a long-term and a short-term remedy. Because we can always have the trainees, the more senior trainees
Under the
start work
supervision.
instead of waiting for that 6 years basically of training before they're able to do one eval.
Hmm.
So I guess it would be senior trainees in a role of a resident to evaluate patients to
I like-
counsel.
So trainee under the supervision of the senior
Yep.
LCSW.
Social
Yep.
worker, resident assistant.
Yeah.
Oh, okay, that's cool.
Trainee under the supervision of senior LCSW. Yeah, that's a good one.
I was also just thinking now, I'm just getting creative, I feel like, but like a virtual telephone, 1-800 number to call. if
No,
you
that's
are in
true. Actually,
crisis mode.
that's actually a very good idea.
Telehealth.
Yeah, telehealth. That's basically
Yeah,
what telehealth
Pretty
is.
much.
The only
I don't
the
know.
only thing is with these particular type of service, I'm not sure what that.
Yeah,
Do you see that as a possibility, Kushbu, for this type of service?
Even if you do telework, you will still need that social worker, right? To do
Right.
Yeah.
those televisits. Yeah,
So yeah, if it's telehealth, then
What
you could
they're
actually
saying
do it for.
Using the
video
the-
visits.
hire outside agency staffs for that.
Yeah, then it'll be outside agencies, but you'll have more options because if it's after hour, there you can get someone from out of the area to do it.
That's true.
You don't
different
need someone
timeline.
in person.
Yeah.
So the options opens up for you.
I don't know, I feel like I don't know the scope of a
Yeah,
license.
same. I don't know what the.
Well enough, like we need
Yeah.
to know.
That's why
like,
I'm trying to think.
resources
But if
to,
it
like,
isn't, if it isn't, then that could be an option. I mean, I was just thinking in my head, I know just based on data, the remote workplace telehealth just kind of increased.
It increased exponentially, and it's not just for one field, it's in a lot of different departments here as well. Mostly these consult types of stuff. We could just add it in now and then see.
Just as a
I
short
mean,
term.
just an idea.
For
But
our
yeah, short
clinic,
term.
we can, yeah, for our clinic, because we make our own policies, right?
Mhm.
Certain places, they would need all that licensing and
Mhm.
all of that other requirements for you to have somebody remote from another state helping the patients.
So contracting with virtual LCSWs, right?
Mhm.
Hiring 10, yeah,
Just a thought, just an idea.
That's a good idea.
it is.
Even for the long term, I think that would be a really good idea.
Yeah.
And it-
People,
it, like,
that's
what-
actually really like
when we say,
competitive.
like, virtual licensed like clinical social worker, they actually don't have to even be out of state. It could just be at a distance, right? It could be
Mhm.
just from a licensing.
Yeah, because during our
perspective.
pandemic, our social workers were all remote.
Yeah, everybody was remote. They're doing more video visits.
Yeah, so we could make something.
Yeah,
valid
because I
using
know like
license.
depending on the profession, sometimes if you're in California, you have to get licensed in California. So
It could be contracting or it could be a policy change within the organization. So maybe that's I think you have one that talks about recommendation for wage increase to senior leadership. Maybe under that could be another recommendation for
Compliance.
off-hour virtual LCSWs counseling.
All right, it's 7. Don't we have office hours right now?
7:30.
Oh, okay, good. Whew.
But I think we're almost done here too.
Yes.
I think we have a good list.
Mhm.
I really
Yeah.
like that virtual idea, Jenny. I don't know why we didn't think about that, but a lot of departments are still very much against it. Like as a whole, the
Yeah. We had
a lot of bigger institutions are like very strict about their policies for counseling and
because
face-to-face
it's
contact.
different. It's
Because of the
different, you're
cost
not used
also,
to it.
yeah. The reimbursement that you get, the telephone visits are the
Different,
lowest.
yeah.
Extremely low, if
Yeah,
if even.
But
yeah.
it, yeah.
Yeah, UCSF doesn't usually charge for them at all because we don't try. It's
Mm.
not worth trying.
It's either video visit or in person. And a
Mhm.
lot of patients, knowing that they have been virtual for the last 2 years, they don't even want to be virtual anymore. They're requesting for them to come in person and see the doctor.
Mm.
Maybe like a short-term thing.
Yeah, no, it's a good idea for this one because for the specialty that we're talking about, it makes sense to have
Yeah,
video
because they can
appointments.
follow up
Yeah.
too.
Yeah,
Recommendation to change
Uh,
policy.
Yeah, change policy related to ratio, right? The ratio. So like if you go virtual, you technically could be more efficient.
more
And then
patient.
Mhm.
break the policy of certain ratios, patient to provider ratio, so it would go in hand to recommend like a change in policy related to
Inclusion of telehealth.
related to OCSW
Yeah,
ratio. To how do I
To
wanna-
patient or provider.
to provider.
Should it be to patient or to providers? Depends on the,
Recommendation.
it has to be dependent on the specialty because in some specialty, there could be a whole lot more.
Yeah,
So just say patient or
Both.
providers. It's okay, whoever wants to make the decision.
Oh,
Okay,
sounds good.
I think that wraps us up.
yeah, good job, everyone.